Just a little introduction for those of you who are not very clear about ECV. We do know that aortic stenosis, and we've had these wonderful talks by our senior faculty about aortic stenosis and the associated amyloid. The deep margin behind that is that we do know that in aortic stenosis, because of its long-standing disease, there is myocardial fibrosis. And the good news is that we can measure it. What we also have known by MR studies is that there are two distinct types of fibrosis. The first is the focal replacement fibrosis, which is basically cell death and replacement. And the second is the diffuse interstitial fibrosis, which happens at the matrix level, which we believe can be reliably reversible. Now, both forms of fibrosis can be detected by MR. And the first one, the replacement fibrosis or cell death, is measured by the gadolinium enhancement, and we know that it is irreversible. However, the second one, or the matrix involvement, is detected by the newer T1 mapping techniques, and we believe that the early use of SAVR or TAVR, as Dr. Govind has already talked about, can bring about a reversibility. Now, this is a little complex algorithm that we use to detect the ECV, and it involves blood filters and matrix filters, and then finally you get the ECV map. Basically, here we do the T1 map before, we give contrast, and then at the end we do the T1 map again, and we calculate the ECV, and this is all a software-based calculation on the MR, but you need to have those tools on the MR. And they are better on 3T than the 1.5T, but you can do it on both. Now, we do know that the myocardium has cells and matrix, as you can see here. And we do know that the focal scarring, which is represented by the gadolinium enhancement, which have been very good over the last decade or two, is reliably picked up on the MR. But recently, we have started discovering how we can look at the matrix. And if you look at this cartoon, you will see that there are cells and there is matrix. And if you replace the valve early enough, you may get a matrix regression only and your ECV drops. However, if you do it a little later, you may just get a cellular regression, and then the ECV actually increases, because we know that ECV is a measure of matrix and not the entire left ventricular mass. And you can get both a cellular reduction and a matrix regression, and there the ECV will remain constant. So ECV is basically a measure of the matrix. And the advantage here is that by decreasing the pressure or by removing the pressure overload, you can have a reduction in this interstitial fibrosis. Now, if you look at the ECV measurements, and this is pre and post AVR, you can clearly see that as the ECV comes down, there is a regression in the mass. There is also a regression in the end diastolic volume. So ECV seems to have a direct correlation with the mass and the volume. And what is again important here is that if there is gadolinium enhancement on the MRI before AVR, that is not going to change. But what is going to change is the ECV. The ECV will come down provided you have intervened early. Now, since this is a new concept, let us look into some of the evidences that are available with ECV and aortic stenosis. And this is generally all from the MR data, where they have looked at patients who were going in, who had severe aortic stenosis to start with, and they had an MRI before and after the aortic valve replacement. Now, if you look at the ECV, you can clearly see here that there is a direct correlation with an increase of ECV with all-cause mortality and cardiovascular mortality. And even within the tertiles of ECV, you can see the ones with the highest tertile also had the highest mortality. So ECV, we now know, is directly having a clinical correlate in terms of all-cause mortality and cardiovascular mortality. And even if you take into account the age, male sex, and an LV dysfunction and gadolinium, ECV by itself is an independent marker for all-cause mortality. So it is very imperative that we measure it. Among the levels of ECV also, you will find that the highest tertile of ECV has the highest mass. The highest tertile of ECV has the highest LV diastolic dimensions as well. So even among the ECV, there is a way to actually quantitate it. Even if you add gadolinium to this mix, the same amount of gadolinium, if you have a higher ECV, you can see that the gadolinium is correlating with the ECV. And there is a negative correlation with an increase of ECV with an EF. So higher the EF, higher the ECV, lower the EF as well. Now, while we have very good robust MRI data in the measurement of ECV, we have the very objective T1 maps that are available. And unlike the plain T1 where we look for edema or early fibrosis, ECV is across the MR scanners and it is across institutions. So while I may have some very specific T1 values for what is normal or abnormal, but the ECV does not matter on my scanner versus your scanner. So that's a big advantage. Now, we do know that CT is a very important tool for taking up patients for TAVR. It's the major tool. So people have now looked at measuring ECV on CT before they went in for a TAVR and to see how the ECV looks like. Now, how we did that was we use a dual source or a single source dual energy scanner. They are completely different from the run-of-the-mill 64 or 125 scanners that most of us use. These have a dual energy and therefore they can also measure the myocardial volume and ECV. So they were able to do this by just adding a 3-minute extra protocol from the routine CT, that is what we call a post-contrast delayed enhancement, and using this software, they were able to pick up the ECV. And what they showed that even with the ECV that they collected from CT, they found that the composite outcomes were much higher in terms of death, hospitalization, and also cardiac events for the same patient who underwent a TAVR. And there was a very good correlation between the BNP levels. Higher the BNP, higher the ECV, lower the EF, higher the ECV, and there was no correlation between ECV and the traditional marker that we do on CT, that is the aortic calcium score, surprisingly. So we now understand the importance of ECV. We know we have a gold standard test in MRI to measure ECV, but now we do know that even on CT, provided you have the right scanner, which I mentioned could be either a single or dual source, dual energy scanner, that's important. So in any way these are done before a TAVR procedure, we know that they are done. So you can get a measure of the ECV before going in for the scan. And what is the advantage is that you get the prognosis as well before doing the procedure. So you know how well this person is going to do. This is especially going to be important with what Dr. Govind was saying. There's an emergence of people wanting to do it even with amyloid. So you will get an idea of how this patient is going to behave if you have a ECV beforehand, and it can be done just by the CT. You don't need any other additional tool. So when they looked at the correlation between the data that comes out from the MR using the Molly recovery sequences, they found that the variability was very low and the MR-derived variability and the biopsy were very, very similar, showing that there is a very good histopathology correlation between what you get on MR, and now we are getting the same information on CT. So, and again, this is again small data coming in from CT data, because you know these are high-end scanners and most of us don't use it. And this is data looking both at MR and CT done for the same patient, and they found that the correlation is quite good whether you did an ECV by MRI or you did with CT. And the iodine maps, as I already mentioned, are the ones that are able to do the ECV, but you do need to have a dual energy scanner. Now, if you look at the difference between aortic stenosis pure and aortic stenosis amyloid, again, the CT, the ECV derived by CT helps us in doing that. And you can see that when you have a patient with associated amyloidosis, the ECV shoots up to beyond 45. 35 is generally what we take in our MRI lab for an abnormal ECV. And compared to lone AS, you can see the one with amyloid is way up there. So there's no way of missing. And this is the basic algorithm that we follow. that once we do the ECV, we look at the ECV, this is more than 31, there is a high likelihood of cardiac amyloidosis associated with aortic stenosis. And using your traditional tools of the immunofixation for AL and bone scintigraphy using pyrophosphate for the ATTR, you can make those variants out. But however, if you have an ECV of less than 30, generally the chances of amyloid is very, very low. So therefore, in patients who are undergoing aortic stenosis, who undergo CT as part of the pre-TAVR workup, by using a low-dose protocol and a 3-minute pause delayed in a very specific scanner, using either single source or dual source, dual energy, we can pick up the ECV, and using the ECV, we can see how these patients are going to behave post-operatively. So, therefore, ECV, as you know, is a very important prognostic marker. It has a direct clinical correlate in terms of cardiovascular and all-cause mortality. We know that the replacement fibrosis by gadolinium and MRI is irreversible. We can't do anything. Many of our patients come late. But the interstitial fibrosis by ECV, we know, is possible to regress once you do the aortic valve intervention. And possibly that is the reason why Sir showed in the last couple of slides that even those with amyloid, even those who have a traditionally sort of short lifespan, actually do well with the procedure, because it is possible that the ECV is coming down. ECV is an important marker. We have a way of picking it up, and it has got an excellent correlation with the ejection fraction, the LV mass, and the atrial volume. And we believe that ECV is going to be a powerful predictor for future events. Thank you very much for your patient listening.